Hello, and welcome to the next lecture in this series covering the Anaesthesia Novice Initial Assessment of Competencies. This lecture will cover post-operative oxygen therapy. The learning objectives for this session include discussing why it's important to maintain normal oxygenation following an operation, understanding the common reasons for hypoxia in the post-operative period, how to decide on an appropriate post-operative oxygen strategy for individual patients, including the prescription of oxygen, and an idea of some other curriculum items that you may be able to link to this assessment in order to maximise your work-based place assessments. So the IAC code linked to this lecture is C06, and this is discuss how the trainee's choice of post-operative oxygen therapy was made. And here below are listed some other items that would be relevant to link to this assessment that you can find in Annex B. On this work-based place assessment, you can see below where you can link to the IAC code, and the curriculum competencies link above where you can link to the additional competencies that may be relevant. Maintaining adequate oxygenation is one of the key priorities of the anaesthetist, and this is including in the post-operative period. We are all aware of the significant detrimental outcomes associated with significant hypoxia, but running through a few that are particularly relevant in the post-operative period include in the cardiovascular system, hypoxia leading to a type 2 myocardial infarction, particularly in susceptible patients with significant coronary artery disease. It has been shown that even short periods of mild hypoxia can contribute to post-operative cognitive dysfunction, especially in elderly patients. And in post-operative patients, inadequate oxygenation can impair wound healing and lead to an increased risk of surgical site infections. The causes of hypoxia in the immediate post-operative period can be divided into factors which cause a reduced oxygen delivery to the tissues and factors which cause an increased oxygen consumption. Hypoventilation is a common cause of hypoxia in recovery. This can be due to the residual effects of anaesthetic agents or medications and drugs given intraoperatively. Common culprits include neuromuscular blockers that have been inadequately reversed and opioids with their depressant effect on the respiratory centre. Ventilation perfusion mismatch within the lung is common post-operatively, and if significant can result in hypoxia. Reasons for this include atelectasis, which is aggravated by positioning intra-op, for example the Trendelenburg position, and invasive positive pressure ventilation. The image on the right depicts a CT scan of the lungs before and after induction of general anaesthetic. You can see even immediately after intubation the formation of atelectasis within the lung, which will only worsen over the course of operation. Other causes of ventilation perfusion mismatch post-operatively include pulmonary edema, which might occur from administration of intravenous fluids, aspiration of gastric contents, which as anaesthetists we are always vigilant about, and if this occurs it needs to be managed appropriately. Pneumothorax, which is a rare cause of hypoxia post-operatively, but can be as a result of intraoperative central line insertion or laparoscopic surgery. And again, it's essential that this is investigated and managed appropriately. And pulmonary embolism, which is of higher risk in patients who have had prolonged procedures or have active malignancy. Oxygen consumption can be increased in the postoperative period, contributing towards hypoxia, and this can be a result of shivering caused by anaesthetic drugs, the surgical stress response following an operation, and also in cases of severe postoperative pain. Minimizing each of these can hopefully reduce oxygen consumption in the postoperative period and help prevent postoperative hypoxia. So, how do we go about choosing oxygen therapy in recovery? First of all, it is essential that any reversible causes of hypoxia have been ruled out, as discussed on the previous slide. So, pneumothorax, aspiration, etc. But some factors that may contribute to the type of oxygen therapy chosen, I've divided these into patient factors, anaesthetic factors, and surgical factors. Some patient factors that may affect the choice of therapy include patient age. Particularly in the paediatric population, there might be issues with complying with the method of delivery of oxygen, and patient comorbidities that you might want to consider that could increase the risk of postoperative hypoxia. So, for example, patients who are heavy smokers, pre-existing lung pathology, obstructive sleep apnea, and some musculoskeletal disorders like ankylosing spondylitis. Anaesthetic factors to consider include regional techniques where actually supplemental oxygen, if using just a purely regional anaesthetic technique, may be unnecessary. Patients who have had a sedation or a general anaesthetic, supplemental oxygen is normally provided intra-op and in the immediate post-operative period, and also consideration of the medications that have been given intraoperatively, for example, use of high-dose long-acting opioids, which may increase a patient's risk of respiratory depression and hypoxia in the recovery room. Some surgical factors to think about, so site of surgery, particularly surgeries that have involved the lung, like a lobectomy or the airway itself, and the likely pain severity associated with the operation performed, which may result in use of strong opiates in the postoperative period, putting patients at risk of hypoxia later on in that recovery period. For patients undergoing general anaesthetic, the anaesthetist is in charge of deciding the amount of supplemental oxygen to provide during the course of the anaesthetic. But as patients are recovered in the recovery room, on the whole, in most trusts, the anaesthetist looking after the patient will decide on a target saturation that would be appropriate for that patient and hands this over to the recovery staff, and they select a method of delivering oxygen in the postoperative period that would achieve these saturations. The AAGBI has the minimum acceptable standards of monitoring guidance for both intra-op and postoperatively, and this states that pulse oximetry is mandatory for recovery of patients. For patients with no significant lung pathology, it's generally accepted that targeting SATs of 94 to 98% is acceptable for most patients. In patients with significant COPD and with evidence of hypercapnic respiratory failure, target saturation should be adjusted to 88 to 92%. It is important that this is both clearly documented in the anaesthetic notes and verbally handed over to the recovery staff looking after the patient. This simple flow diagram helps guide the choice of post-operative oxygen therapy. On the top arm, we can see, is there a need for a delivery of a high inspired concentration of oxygen? So generally in elective patients this is not going to be the case, but in that emergency cohort who are very unwell and requiring a significantly high FiO2 intra-op, it might be appropriate to consider keeping the patient asleep and intubated and transferring them to critical care. As a novice anaesthetist, this will clearly be something that will be discussed and senior anaesthetists will be involved. So on the bottom arm would be most of the patients that we see who are appropriate to wake at the end of the procedure. So supplemental oxygen is supplied for transfer to recovery. This is normally through a water circuit attached to the airway, and this is a risky period for the patient as they are transferred from the operating room to the recovery, as generally saturations are not monitored during this period and we rely on our clinical signs, so signs of cyanosis, which is quite a late sign of hypoxia. Patients should be appropriately handed over to the recovery staff looking after them, and a selected target saturations should be verbally handed over and also documented in the anaesthetic chart. And in addition to this, oxygen is then delivered to the patient via appropriate device until it's no longer required to achieve the target saturations. Most patients will not require supplemental oxygen following discharge to the ward, and certainly day case patients need to be able to maintain their saturations without any supplemental oxygen. Some patients, for example, patients with morbid obesity, may have some residual atelectasis and ventilation perfusion mismatch, which would require ongoing increased inspired partial pressure of oxygen for a longer period. If there is clinical concern that patients are requiring a high concentration of inspired oxygen longer than what would generally be expected after an anaesthetic, then this needs to be appropriately investigated for other causes of the hypoxia. These are some of the oxygen delivery devices commonly used within the recovery room. So from left to right, we've got the water circuit, which with a complete seal and adequate flow can deliver a FiO2 of close to 100%. Next is the non-rebreathe mask, which with a flow rate of 15 litres a minute can achieve close to a FiO2 of 90%. The Hudson or simple face mask, which is probably one of the most commonly used devices, can deliver an FiO2 of around 30 to 40%, depending on the flow rate. Then Cheery devices can deliver a wide range of inspired pressures of oxygen, but are not used so commonly in recovery. And on the far right is the nasal cannulae, which can deliver a max FiO2 of around 30%. But it is worth noting that prolonged use can cause quite severe drying of the nasal spaces. As I mentioned before, oxygen should be prescribed in the post-operative period, as it should when we are using it in any setting. And generally, the amount of oxygen administered should be the minimum needed to achieve the desired target saturations. And these target saturations should be specified on the drug chart. And just to reiterate the point that patients with ongoing significant oxygen requirement post-operatively do need a clinical review and to be worked up appropriately. As we know, there is increasing evidence that very prolonged periods breathing high concentration mixtures has negative effects on physiology. The vast majority of the patients we see following a general anaesthetic will only require supplemental oxygen for a limited time, so would be at very low risk of experiencing these effects. But just for completeness, these effects include within the cardiovascular system, coronary and systemic vasoconstriction. In the lungs, high inspired concentrations of oxygen can cause atelectasis, resulting in a reduction in FRC and increased ventilation perfusion mismatch. And at very high partial pressures of oxygen, cerebral vasoconstriction can occur, resulting in reduced cerebral blood flow. The effects of all of this can be minimized by only delivering the minimum amount of supplemental oxygen necessary to achieve the desired target saturations that are documented. And just to recap, hopefully you now have an understanding of some of the common causes of hypoxia in the recovery, some of the factors to consider when deciding on post-operative target saturations for patients following an operation, some of the common methods of delivering oxygen in order to achieve target saturations in the post-operative period, and to recognise the red flags when patients may need further review and investigation if ongoing requirement for high levels of supplemental oxygen. Thank you for watching this mini lecture, and if you have time, we would much appreciate it if you completed our Survey Monkey, which there is a link below the video, to give us some feedback on how we can improve our content.